All right, so break after this session. You can get up and stretch your legs and get some caffeine. It's my pleasure to chair the session on quality of life in neuroendocrine tumors. You've heard many of our speakers today talk about the importance of, particularly in the setting of managing disease which is not curable, trying to balance the impact of the cancer, living with the cancer diagnosis, and the effects that that tumor can have on a patient against the things that we do to try and help manage that disease, maintain quality of life, and hopefully help people to live longer. Ultimately, for an individual patient, we can't necessarily tell you, we can't measure that you're going to live longer. Our treatments might do that for you, but we can certainly, on a day-to-day basis, based on what you tell us, understand the impact of the disease you're dealing with and what our treatments do to you. So ultimately, I think in many ways, the questions around quality of life are more important than quantity. And so I'm really pleased to see the focus at CNET's at this part of the session to try to address some of those issues. And so with that, I will turn it over to my colleagues.
I'm back. So my task that I was given is to talk about the cognitive impairment in patients with carcinoid syndrome, something that I've been very interested in and quite passionate about. My objectives is that we're going to go through some of the biochemistry of carcinoid syndrome. Some of you already know it very well, but we'll touch that. And we're going to examine some of the neurocognitive changes that are observed in patients with carcinoid syndrome. Discuss some of the potential causes. You'll see my bias come out loud and clear as we review some of the data. So carcinoid syndrome is a constellation of symptoms that occurs in patients with metastatic neuroendocrine tumor. And many of you in the room are well aware of these symptoms: the flushing, diarrhea, valvular heart disease, abdominal pain, bronchial constriction, and vitamin B deficiency. We believe that carcinoid syndrome is predominantly mediated by serotonin when it comes from the small bowel neuroendocrine tumors, histamine when it comes from the gastric neuroendocrine tumors, but as we heard earlier, a bunch of other peptides that these tumors may be secreting that we don't know anything about. The liver is an incredible organ, and so when these compounds are then released into the portal system, they go up to the liver. The liver is able to deactivate these active peptides the majority of the time. So in order to get carcinoid syndrome, those chemicals, those amines, have to have bypassed or beyond the deactivation of the liver. And that means that you have to have either liver metastases, significant liver dysfunction, so the liver can't keep up its function. Some patients have had a huge tumor production of it, so it overwhelms a healthy liver, or the tumor is dumping directly into the systemic circulation and bypassing the liver altogether. The majority of patients with carcinoid syndrome come from the small bowel neuroendocrine tumors. And this is a slide from James Yao's group looking at the Sears database. It was presented at eNets just recently, and it really just tells us that it appears that the percentage of patients with small bowel neuroendocrine tumors, about 19%, will have carcinoid syndrome. Many of us that work at centers of excellence and where we have a focused practice have a much higher percentage. Ours is probably closer to 40–45%, but that's the selection bias of seeing patients with metastatic neuroendocrine tumors. So where do we get the serotonin from? Well, it comes from the precursor tryptophan. And once again, for those patients with that have ever done a urinary 5-HIA, I don't have to remind you of what the tryptophan-rich foods are: the cheese, the grapefruit, the cantaloupe, the kiwi, all of the things that you're asked to stop weeks before you do your urinary 5-HIA. But we get our tryptophan from our diet. We then, it is then broken down to 5-hydroxytryptophan, and then decarboxylated into serotonin. And serotonin is then stored in the platelets and moves throughout the body. And then it's broken down into urinary 5-HIA, and that's what we measure. So there's actually two compartments of serotonin in your body. There's the peripheral compartment, which makes up about 90% of our overall serotonin. And that's where the enterochromaffin cells of the GI tract will go take the tryptophan and make the serotonin. But actually, the majority of the tryptophan that you take in your diet is actually shunted into niacin, vitamin B. And it's only a small proportion that makes serotonin. The second compartment in the body is the brain, and here it's the serotonergic neurons that make the serotonin, not the cells from the GI tract. And the serotonin actually doesn't cross what we call the blood-brain barrier. So we have two compartments, one peripherally, 90% of our serotonin, and then the brain independently makes its own serotonin, all from the tryptophan we take in our diet. So what does the serotonin do? Well, in the peripheral group, it is responsible for platelet activation. It regulates the GI smooth muscle. It causes peristalsis and vasoconstriction. In the brain, the serotonin is actually a neurotransmitter, and it's been implicated in many different diseases that have cognitive dysfunction. And that's one of the reasons that serotonin inhibitors are used to treat depression, to try to keep the serotonin level in the brain up. But it's been studied in anxiety, Alzheimer's, and schizophrenia. Now, it's estimated that when you have a small bowel neuroendocrine tumor, that it will consume up to 60% of your tryptophan to be able to drive its own mechanism. And so it's shunting the tryptophan away from niacin and making serotonin from the tumor itself. And Dr. Shaw, in collaboration with us, we went on, and others have shown that there is a relative niacin deficiency in patients with carcinoid syndrome. So in other words, if we take this mechanism where most of the tryptophan is made into niacin, when we have a small bowel neuroendocrine tumor, it's shunting and we have more serotonin in this peripheral group, meaning we have less niacin, less tryptophan, because it's all going this way, and remember, it doesn't cross the blood-brain barrier. So we actually have a tryptophan deficiency, which may cause a decrease in serotonin in the CNS. Osler, and obviously Sylvia also has a fine passion for the great clinician of Osler, who said the best teaching is taught by the patient himself. And so in our clinic, so when we started to then see all of these patients with carcinoid syndrome, we started to see some patterns. And after seeing over 80 patients with carcinoid syndrome, it was actually my secretary that sort of drove me to sort of looking more at this. She was complaining that these patients were very high maintenance. And what I mean by that is that they kept forgetting instructions. They kept, no sooner would they leave the clinic that I would see them, and they'd be phoning her office and said, she said something really important, but I can't remember what it is. And we started noticing that they neurocognitively just behaved differently than other patients that suffered from metastatic cancer that were more commonly seen in the cancer center. And what really triggered it as a surgeon is I would spend 45 minutes drawing these elaborate pictures, showing them what I was going to do from an operation point of view. They'd show up into the holding area of the hospital to get their operation. And any of you that have had an operation, you know the first thing on the safety checklist is they say, do you know why you're here? And they'd go, no, I don't have a clue. That was ruining my day before it even started. And so it really then got us thinking, is there something else going on? And so if we looked at this, is it related to a tryptophan deficiency, or low serotonin in the brain that's causing subneurocognitive dysfunction. And it's interesting, you can actually create tryptophan depletion biochemically by giving an amino acid solution that can drive the tryptophan down, and that has been shown to decrease the serotonin production in the CNS in animal models by over 90%. And then when they moved that to clinical humans, they found that neurocognitively, when you have tryptophan depletion, there's a decrease in visual and verbal delayed recognition, visual spatial impairment, a decrease in the ability to relearn, and impaired long-term memory. Also, there's another drug that has some decrease in the serotonin effect, the serotonin in the brain, and that's actually Ecstasy. And that actually causes a degeneration of these neurons that make serotonin in the brain. And people on Ecstasy also have slower, complex attention abilities. They have impairment of their visual learning and a decrease in their memory. So we weren't the only ones thinking of it. Rusko, I think, was one of the first that also looked at this problem and said, let's see what kind of cognitive impairment they have compared to depressed individuals, and did a pilot study of 21 patients with Carcinoid Syndrome and showed that many of the cognitive dysfunction that they were displaying mimicked that of what we see when we deplete tryptophan acutely in patients. So we then proposed a study where we wanted to evaluate the cognitive performance in carcinoid syndrome patients and compare them to age, education, and gendered match norms from the North American population. But we also knew that having the diagnosis of metastatic cancer is impairment in itself, and that could be causing a lot of these symptoms. So we wanted to see how they would compare to patients with adenocarcinoma, non-neuroendocrine tumors that were also metastasized to the liver. And so we got 36 patients with carcinoid syndrome, 20 patients that had non-neuroendocrine metastatic disease to their liver, and we put them through two types of testing. The first one was a patient self-assessment. This is a validated tool. It was 38 questions that asked about cognitive performance, and this is the patient self-assessment looking at these 5 cognitive domains: language, attention, visual perception, and visual and verbal memory. And they would then rank this. With the help of a neuropsychologist, Stuart Longman, we came up with a battery of 6 neurocognitive testing that once again would look at these cognitive domains of executive and visual and verbal memory using a battery of neurocognitive tests. When we compared, so let's look at the self-assessment. So this is the patients with carcinoid syndrome. These are their age, gender, and education match norms. And on all of these cognitive domains, the carcinoid syndrome patients scored higher, meaning they were having more cognitive difficulty than the norms. And they were also higher in their self-reported cognitive dysfunction, even when we compared them to those with adenocarcinoma of the liver, but not as robust. When we look at their neurocognitive testing, this would be the carcinoid patients. This is the healthy norms, and we found that their visual memory was impaired. We found that their verbal memory was different. Their attention and concentration was different. And I'd like to just illustrate what this visual memory deficit that they have and why this, I think, is so important. This is a picture that they're asked to draw. It's got 18 elements on it, sits in front of you, and you're said, copy this while it's sitting there. But we're going to take it away, and at different points in this test, we're going to ask you to recreate it. So while you're drawing it, your brain has to then take that visual memory and put it into something you could then recreate. Our carcinoid syndrome patients were drawing pictures like this, and on average, they were missing 2 elements of the picture when the picture is sitting in front of them. So then when they were asked to recreate this, both immediately and delayed, that picture would just disappear. We found when we compared that the carcinoid patients to the non-neuroendocrine patients, they also showed a difference in cognitive impairment, but it wasn't as robust as compared to the norms. And we wondered if it was related to the fact that our non-neuroendocrine patients were also on chemotherapy. So from this study, we summarized that the patients with carcinoid syndrome report cognitive dysfunction higher than their norms. And on formal neurocognitive testing, we showed that they were quite different than the age and gender matched norms. So cognitive impairment, I believe, does happen in carcinoid syndrome, but why? It could be a whole variety of reasons. Sleep deprived, anxiety, depression, they can also cause cognitive impairment. Is it the serotonin or some other peptide that's causing this? There's a bunch of work being done in neuroimmune inflammatory response to tumors that I don't have time to talk about. Is it the somatostatin analogs? Because all of the patients in our study were actually on a somatostatin analog. Or where I have led you guys down is it's got something to do with tryptophan deficiency and a decrease in the CNS serotonin. And why does that become important? Because we have a drug now that hopefully we'll be getting in Canada, telotristat, which blocks the tryptophan conversion to 5-hydroxytryptophan. And so in some ways, it will prevent this tryptophan deficiency. So what's our future direction? Well, we are looking now to validate what we found in Calgary by a Canadian-wide validation study, looking at a similar study that we've done, and I'm pleased that Tim is keen on doing it in Ottawa and several other centers across Canada with the help of ComNets. And maybe with a bigger group, we can look at cognitive dysfunction before you get treated and after treatment. And we can then expand this to New Zealand and Australia. They're both keen on working on this once we can validate it. And then I think there's going to be promise in looking before and after telostarate. So in summary, I believe there's a cognitive dysfunction in carcinoid syndrome. We have put it in as part of the symptomatology of carcinoid syndrome. It's completely changed my communication style. It's no longer pictures as solely. It's got to be a combination. And we now use the cognitive part with our patients as we try to take them through their journey in palliating this disease. So with that, I will end. Thank you.
Good afternoon, everyone. I would like to thank the organizing committee and CNETs for inviting me today to talk about this very important topic, of course, which is the symptom management of patients with neuroendocrine tumors. These are my disclosures. So my objective today in this brief but very important 15-minute talk is to define what functional versus symptomatic neuroendocrine tumors really are, describe the so-called carcinoid syndrome, and also describe medical treatment options for patients with the carcinoid syndrome. So we've seen this slide as well, but I'd like to walk you through this again. And whenever I have medical students or residents in my clinic, I always pull this one up to just get people thinking about neuroendocrine tumors in general and about the very important aspect of these tumors, which is the symptoms that they cause our patients. So my disclosure as well is that I'm a gastrointestinal medical oncologist, so I won't be talking that much about lung today. My apologies to the lung people here in the room. But just kind of going and focusing on the blue here, that with gastrointestinal neuroendocrine tumors, we divide them between functioning and non-functioning. And you can use various measures for that. One of the ones that we've heard today is those tumors that produce serotonin, and we can capture that by the measuring the urinary 5-HIAA. And then patients who then have symptoms, and I'll define what those symptoms are in just a minute. So just walking through this again, we have patients with neuroendocrine tumors, the gastrointestinal ones, which I'll mainly focus on, and the functional versus symptomatic. Oh, pardon me. go back one slide. So this is a case I always go over with my trainees. 49-year-old female, has hypertension, has a history of diarrhea and flushing. This is the picture noted at the top of the screen. This isn't a real patient from Ottawa. This is actually just pulled off Google Images. If you do carcinoid syndrome, she's the one or two top ones there. On exam, we see in clinic there's this obvious flushing with this pinkish, purplish, hot face and upper chest. Otherwise, the medical exam is fairly good. The liver is a bit enlarged, however. So, of course, this patient sees a lot of doctors, even goes to an allergist, and thought that the diarrhea might be related to the food, but lo and behold has this test called urinary 5-HIA, and it's quite elevated. So what clinical syndrome is this? And I'm not asking you guys, I usually ask the medical student because we're here at a carcinoid meeting, of course, so everyone knows the name to this syndrome. So again, Janice walked us through this one as well. This is our main biomarker that we can use, the urine 5-HIA. I always tell patients, this is the one you carry the bucket around for 24 hours, not the most pleasant one. People get very annoyed when our lab mistakenly throws out the bucket and they have to use it again. Happens every now and again. And so moving on here, this is the syndromes with so-called nonspecific symptoms caused by NETs. And this is a busy slide, but really I'm going to focus on the so-called carcinoid syndrome. But again, I only have 15 minutes here today, so I can't go over all of the syndromes associated with neuroendocrine tumors, but they're here for your reference, and I can freely share these slides. So this is the classical presentation that we teach all of our medical students about what carcinoid syndrome is. And we've heard about flushing and diarrhea, but there's other aspects to this as well. The very important cardiac disease, there can be skin rash associated with this, bronchoconstriction in some patients, and we always have to think about this entire constellation of symptoms when you're thinking about the carcinoid syndrome. Now, just a bit of an aside here, Dr. Simran Singh, who's been at this meeting as well, did this very important work that, we all think we're very smart doctors, but in fact, it takes doctors a long time to make this diagnosis. And with Dr. Singh's patient survey, it found it took 52 months from the onset of the first symptoms to the diagnosis of neuroendocrine tumor. And on average, patients are seeing at least 6 different healthcare providers before this diagnosis is made. This is no surprise to this audience, I know. So, back to the symptoms of the carcinoid syndrome. We've talked about this. You get these vasomotor symptoms, increased intestinal mobility, noted with diarrhea. You can get heart failure from this fibrotic effect on the heart valves, bronchoconstriction. And then we haven't talked a lot about that at this meeting, but the so-called carcinoid crisis. Hopefully this is something that never happens, but this is a very severe form of the carcinoid syndrome that's usually brought on at times of anesthesia or surgical manipulation or biopsy, and hopefully we can identify patients at risk of this and prevent this before it happens. So of course, what is flushing? And I do spend a fair amount of time with my trainees going over this because, there is hot flashes that, people in a perimenopausal state will have, but then there is flushing, and there is a real difference between the two. So 75 to 80% of patients with the carcinoid syndrome have small bowel carcinoids. The manifestation severity is very patient variable. That's why it's always important to have a unique and customized approach with each patient. These flushes typically last 20 to 30 seconds, and for anyone in the room who hasn't seen one, we see them in clinic sometimes. The patient will be sitting there and just this red violaceous rash kind of spreads from the upper chest up to the top of the head. Sometimes the patient knows that it's going on, other times that they don't. This can also be associated with a fall in the blood pressure and increase in the heart rate. So what about diarrhea? Never a nice thing to talk about, of course, but diarrhea is not nice, and you guys know this all too well. James Yao did this great study that shows that your health-related quality of life definitely goes down when you're having more than 4 bowel movements a day. Now, it seems like common sense, but he's proven it, and there's the paper to prove it there. And so certainly we need to be able to control this better. So the mainstay of our treatment in the clinic for decades now has been somatostatin analogs. There is a few types that are available. There's this octreotide acetate injection, so that's the so-called short-acting octreotide. And then we have octreotide for injectable suspension. This is the so-called long-acting. This has been approved in Canada for 28 years now, since 1989, for patients with metastatic carcinoid tumors with symptoms. Now, you note some of the older terminology here because this Health Canada product monograph hasn't really been updated since 1989, so they don't use the word neuroendocrine tumor there. And you have two options there, one being the so-called short-acting and one being the long-acting. So how does this work? So these somatostatin analogs binds to somatostatin receptors, and this produces a dramatic reduction in the amount of serotonin and its metabolite and symptoms in patients. We have two long-acting versions of this available, Sandostatin LAR and lanreotide, but only the Sandostatin LAR is approved for this indication by Health Canada in Canada. So what about other treatments for diarrhea? Opiates or synthetic opiates have been used. These reduce the mobility of the bowel, allows the bowel to have more time to reabsorb fluids. It's not commonly used, but that's out there. Then I'd like to spend my last bit of my presentation talking about this new, fairly exciting small molecule, telotristat ethyl, and Janice just mentioned this briefly there. So patients with symptomatic carcinoid tumors can still have persistent diarrhea, and this is actually a fairly common problem. Even if you so-called use the maximum dose, even sometimes above the maximum dose of the SSA. So telotristat is a novel oral small molecule TPH inhibitor, and Janice had a nice slide on that, that does not cross the blood-brain barrier. Now this is very important because older types of this molecule were tried in the 60s and it had very bad side effects with depression because when it crosses the blood-brain barrier, people can get very depressed with that. This one does not have that property. So the TELESTAR study was done. This was a large study by neuroendocrine tumor standards, so there's 145 patients. All of these patients were having more than 4 bowel movements a day and were on appropriate doses of SSA. And they were assigned randomly to a 1:1:1 ratio to receive this new medication, telotristat, versus placebo. So you could either get 250 milligrams of this 3 times a day, or double that at 500 milligrams 3 times a day, or just placebo. So the results were fairly impressive. These 3 bars show the placebo, which is on the far side, and then the 2 different doses of the telotristat, 250 milligrams 3 times a day versus the 500. And what they saw was that the average number of bowel movements was decreased by 1.7 times for the people at 250 milligrams and 2.1 times for the people getting double the dose at 500. Also, very interestingly here, there was a reduction of urinary 5-HIA. And for the clinicians in the room, and Janice, we were all very interested to see that 80% of patients on the telotristat had a over 30% reduction in 5-HIA, which means that this is making, we think, a real reduction in the amount of serotonin that's in the circulation. And as we've heard before, we think that circulating serotonin and its metabolites is bad in terms of prognosis, symptoms, and also fibrotic conditions like the carcinoid heart disease. So they found in this randomized placebo-controlled study that it was generally well tolerated. There was mild nausea, and there were some asymptomatic increases in the liver function tests. Now, very importantly, they looked at depression and serious depression events, and fortunately, there were no serious depression events on patients who were taking this medication. And that reassured everyone that, a significant amount of this was not crossing the blood-brain barrier. Now, which is very exciting, this was approved by the FDA in February and is available in the United States for patients with the Carcinoid Syndrome, diarrhea in patients with metastatic NET. Now, unfortunately, it's not yet approved in Canada, and I don't know when that is going to happen. Typically, these things kind of come 6 months after the US approval, but we'll wait to see when we see that. So in summary, many patients with advanced neuroendocrine tumors have symptoms. The most common syndrome is this so-called carcinoid syndrome, and we spent a lot of time talking about that today. There are effective treatments that are out there, including somatostatin analogs, various supportive care mechanisms, and now telotristat. But certainly more work needs to be done to understand and improve patient experience, quality of life, and symptom control. And I'd also like to direct everyone's attention to this fabulous guide on neuroendocrine tumors. I just read it eating my lunch, and much of what I just talked about is listed in a very readable format in that guide, and I'd be happy to answer any of your questions, also share these slides, and thank you for your attention.
We did very well with time, so I think before we break for coffee, we could take a couple of questions.
For Dr. Janice, taking niacin supplements or anything like that to get past Diarrhea?
Did everyone hear the question?
So the question was whether taking niacin or vitamin B supplements would change the cognitive dysfunction. We don't know because, one, we haven't completely validated it. We're not quite sure what the why this is happening. But I think everybody, most of the clinics would be giving you guidance in making sure that you are taking appropriate amounts of niacin in your diet if you have metastatic small bowel neuroendocrine, because it is causing a relative niacin deficiency. Whether it changes cognitive function, we don't know, but we're going to hopefully try to answer that question.
One more.
Did I understand correctly that lanreotide is not available in Canada?
So it is available, but by the Health Canada indications, only the octreotide long-acting is indicated for symptoms of carcinoid tumor. Now, that being said, lanreotide is commonly used around the world. Some people use it in Canada, but just, when you go by the so-called strict Health Canada label, that is what it says.
Okay, and with that, we'll break for coffee. Thank you.